Hi there, I'm Chris Naples.
And I'm Rob Schlamp. We're both paramedic practice educators with the BC Emergency Health Services Learning Department.
Welcome to our presentation on COVID-19. Today we're going to cover the epidemiology and etiology of COVID-19.
We're also going to discuss the patient assessment and the different testing models. We're also looking at the effects of COVID-19 on each individual body system.
Okay, so when we're talking about COVID-19, the first thing to talk about is that COVID is not new. If you take a consideration of a couple of dates that are probably you would remember, in 2002 we experienced SARS. Now SARS is a direct result of the COVID-2 virus, and you'll notice a trend here. COVID-2 virus is also part of the COVID-19. So SARS, which is a severe acute respiratory syndrome. It was in 2002, and it was a direct result of the COVID-2 virus being contracted by a bat. Now, the way when you get COVID-2, normally it causes things like a runny nose, sore throat, itchiness, nothing drastic like we're seeing from the COVID-19 virus. COVID-2 was initially contracted by a bat, and then it went through an intermediary animal. In the case of the SARS, it was a civet. So through the process, this process is called zoonosis. And through this process, the virus was contracted, it transmutates again through the civet, and finally transmitted to human. Now, as you remember with SARS, it caused a whole bunch of respiratory type syndromes. It was quite a severe disease in 2002. Now let's go to 2012 with the Middle Eastern Respiratory Syndrome, MERS. Same COVID-2 virus, or a variant of COVID-2, but COVID-2 virus to bat, zoonosis through camel to human, causing the symptoms that we saw with the Middle Eastern Respiratory Syndrome. Now, 2019, COVID-19. So COVID-19 is just a mnemonic that stands for the novel coronavirus discovered in 2019. Now again, same COVID-2 virus, contracted by a bat. We think it went through something called a pangolin. Now the pangolin is a highly traded animal within China. Scales are known for healing properties within their cultures, and so it's either a delicacy or medicinal. So it's throughout all of China, which would also kind of equate to why things spread so fast. We're going to get into the spreadability of this in just a moment. But it went bat to this pangolin through to human, and that's where we ended up with the severe disease that we're seeing today. My partner Rob's going to come and talk about the S spike is called, and how that has unlocked the key to this whole situation, which is that mutation process. So that's just a quick brief thing to let you know about how the virus developed, why we're seeing the symptoms that we're seeing right now. But it's also important to look at the fatality rates. So we're seeing a really large numbers of deaths with COVID-19, but if you think about it and when we look at it, it's not as deadly as you would think when you do the math on it. So if we take 2002 SARS and we look at the case fatality rate, we can see that it's a 10%. Now, to get that case fatality rate, what you end up doing is you take the number of recorded deaths, you take the number of cases, divide the deaths by the cases, and multiply by 100. So in the case of SARS, there were 800 recorded deaths with 8,000 cases. So that gives us a case fatality rate of 10%. Looking at MERS, 850 cases. Now it didn't spread anywhere near as much as as SARS, and certainly not as much as COVID-19. 850 cases, 2,500 cases, 850 deaths, resulted in a 34% case fatality rate. Now, that's a really high number. Now let's look at COVID-19. If you look at COVID-19, as of May 5th, 2020, the numbers worked out to be a number of cases. There's 3,606,038 cases. The number of deaths, 252,151. So if you do the math on that, it works out to a case fatality rate of 7%. So the numbers are really high, and the number of deaths obviously very concerning, and has had a huge world impact. But if you look at the actual percentage chance of death, it's sitting at about 7%. So just again to go over the case fatality, really if I had to pick one to get from a personal risk perspective, honestly, I'd probably be looking at the COVID-19 just because of the case fatality rates. So now why don't we move on to the spreadability of the disease. So let's talk about spreadability. With regards to spreadability, it's a concept we need to take into consideration is something called the R naught. So it's represented by this R0 on the board here. And what it really is the reproductive ratio. So what that essentially means is how far and wide does this disease spread? It can be thought of basically as if I'm at a party with a bunch of people and I'm coughing and hacking and I have the COVID-19. What number of people would I likely infect? So we know that with COVID-19 it has an R naught or a spreadability ratio of 2 to 3. So let's take the number 3, just take the worst case scenario here, and let's take a look at it. I'm just going to switch sides here. So if you take a look at it, let's say there's me, and I am at a party, and I end up coughing. I'm going to infect 3 people. And when those people then go to another party that I'm not invited to, they infect another 3 people. As you can see, it's an exponential increase in the number of patients. Now, if you were to take this number R0 of 3, so in this case 1, we go to 3 to 9, and as you can see, then 27 and so on. Now let's compare that with influenza. Influenza has a R naught of 1. So one patient infects another patient, infects another patient. A far less wide spread of the disease. So obviously 1, 1, 1. So both of those can be represented on a graph by drawing the following. If you look at the R naught here, you're going to see an exponential graph like this for COVID-19. Now take into consideration influenza. Influenza will have more of a line like this. And finally, what we're trying to achieve is to have this drop. What we want to see over time is it start to drop like this. So how do we do that? How do we get this to start dropping? Well, it's all of the prevention techniques that we're using currently, which is self-isolation or 6 meter or 6 foot distance. And for healthcare workers, proper protective equipment, face shields, masks, lots of hand washing. Being very cognizant of what we're doing as far as disease transmission goes will help to start flatten this out. So that's what our goal is. Obviously, we've got some work to do to get there, but that's what we're trying to achieve. So that's how wide the disease will spread. The other thing to take into consideration is something called a series interval. Now, the series interval speaks to how quickly the disease transmits. So the best way to look at that, when considering a series interval, is to take a look at this little graph here. In this case, let's imagine we have patient 1. And patient 1 is living their life. They get infected and they start to develop symptoms. We'll call that day 0. Now we know that they've got about a 14-day life of transmission, so that's this graph. Now let's say patient 2 starts to hang out with patient 1, and they start to develop symptoms, or they get infected and start to develop symptoms. That is now their day 0. If their day 0, for arbitrary numbers, we'll say equates to day 2 of patient 1. This space in between here is known as the series interval. Again, that's how quickly the disease will progress. So, studies have shown that the series interval for COVID-19 is 7.5 days. And the series interval for influenza is 2.5 days. So when you think about it, the speed of transmission is much faster. The lower the series interval, the faster the disease progresses. So the speed of transmission is much faster with the flu than it is with coronavirus. So luckily, we have one thing working in our favor. The series interval is longer. We know how quickly the flu spreads. But the reason the numbers are so high still is because of this, that R naught, where we have that spreadability, the number of people infected. If we had this series interval with the R naught of 3 that COVID-19 has, the numbers would be a lot higher and we'd be in a lot bigger trouble than we currently are. So that basically covers off a quick talk about how the disease is transmitted and why the numbers are as high as they are.
Okay, so we're going to talk about how you get sick in the presence of a COVID-19 virus. And this really is translatable to how we get sick from any microorganism. What we think about when we think about how people get inoculated and how people get infected is we look at three aspects. We look at the host, we look at the virility of the organism, and we look at the amount of the organism that you're exposed to, or the viral load. So in terms of the host, in order to make sure, or in order to optimize your chances of either not getting very sick or not getting sick at all, it's to optimize your ability to mount an immune response. And that really requires, from a host perspective, the nutrition, good nutrition, eat well, a balanced diet, stay hydrated, lots of water, lots of oral intake, make sure you're up on your vitamins, make sure you're getting lots of vitamin D, lots of sun. Exercise is super important. Stay healthy, regular exercise, and then of course sleep and lots of rest also is a key component to optimizing the host's ability to fight off any microorganisms. And then if there's the availability of any vaccines or anything that are specific to what might be out there, those are also things that will improve the host's ability to fight off these microorganisms. The next thing we talk about is the virus or the organism itself. How nasty is this bug? Is this something that takes a very, very, very small amount to infect you, for you to become really, really sick, a really, really nasty bug? Or is this something that you need a whole lot of to get exposed to? So things like the norovirus, for example, very, 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 very nasty. Takes a very, very small amount of microorganism to make you sick, even if the host has done all the things that the host can do to maintain good immunity. The other thing is the amount that you're exposed to. So even if you're exposed to an organism that's not necessarily very virile or very nasty, if you're exposed to enough of it, it can overwhelm your ability to respond from an immune response perspective. So optimization of the host, how nasty is the virus or the organism, and how much of this viral load are you exposed to. As we diminish some of these things, so if you don't do all the things to make sure your host is well prepared, or if the bug is really, 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 really nasty, or if you're exposed to a lot of these things, what happens is these circles start to move together and they start to overlap. So when we look over here, if you have a host who's immunocompromised or maybe immunosuppressed or has poor nutrition, dehydration, isn't getting the sleep that they need, has a lack of exercise, and there may be no available vaccines to whatever the microorganism is, these circles come together. The host comes together. If the bug is nasty, these circles come together. If you're exposed to a lot of it, these circles come together. And where this overlaps, and the greater amount of overlap, is where you are at the greatest risk of becoming sick from the exposure to this microorganism. So again, just to review, all the things we can do to make sure the host stays as healthy as possible and is able to mount the immune response that we want them to. We can do nothing about the virility of the bug, but the viral load is something we can do things about. And in terms of COVID-19, to reduce your exposure to the virus or the viral load, these are the things that are going on now. For the public, it's the social distancing. Keep your 2 meters or 6 feet away. It's washing your hands frequently. It's staying home. It's not being out in public in large gatherings. So Chris talked earlier about the R naught. So it's avoiding the opportunity for those things to spread. That is something we can significantly influence. The host we can influence. Stay as healthy, eat well, stay hydrated, take your vitamins, exercise, rest as much as possible. We know this is a COVID-19 virus. We know that it exists. We know that it's a fairly hardy virus, and avoid the viral load. If we get into this situation here where we have exposure, the more these circles come together, the greater that area of overlap, the more likely you are to get sick from COVID-19. So we've talked about the whole epidemiology of the COVID-19 virus. We've talked about how you get sick from a host, virility, and viral load perspective. Now we're going to actually talk a little bit about what happens when you get exposed to COVID-19 and where it affects your body and how it affects your body in some ways. So we know, or we think we know, that COVID-19 is transmitted through droplets. So a droplet could be in the form of somebody who coughs or sneezes or saliva, and if that comes into contact with somebody else's mucous membrane, you have a chance of getting exposed to the virus itself. So it's a droplet transmitted process. What the COVID-19 virus likes to do is it likes to attack our alveoli. And specifically, there are certain areas within our alveoli that it attaches to and creates an issue for us as a host. So when we talk about it being a droplet virus, so it gets inhaled somehow, gets into your mucous membranes, it goes down into your lungs, and it attacks and attaches inside an alveoli. So I've drawn an alveolar cell, or an alveolar here. An alveolar is basically comprised of a number of different cells, but the two main types of cells that were within the alveolar itself are pneumocytes. There's a type 1 pneumocyte and a type 2 pneumocyte. Type 1 pneumocyte being responsible for the transmission of gases. So it allows for the diffusion of gases across that membrane. So oxygen goes in, CO2 comes out. That's what's illustrated in the little blue bumps in this diagram here. The other cell that you see are type 2 pneumocytes, and those cells are responsible for the production of surfactant. And as we know, surfactant production really enables the alveolar to reduce the surface tension of that wall so it doesn't collapse on itself. We want to have that surface tension reduced so that the alveolar stays open at the end of exhalation. So unfortunately, what the coronavirus does though is it attaches itself to the type 2 pneumocyte. But one of the interesting things about the coronavirus this time round, the COVID-19 versus previous times, is there was a mutation in this last iteration. And this mutation was in the form of these S protein spikes. It's very, very similar to previous coronaviruses. It's almost 97+% similar. One of the significant differences though is this S protein spike. And what this S protein spike does is it attaches to this type 2 pneumocyte. And specifically, it attaches to your angiotensin converting enzyme receptor with these S protein spikes. And this is essentially a key to open up and give access to this virus into the cell. So again, the S protein spike binds to the ACE receptor on the type 2 pneumocyte, and it opens up and invites the virus into the cell. Okay, this is really important. Previous coronaviruses couldn't do that. So this is now a new mutation that really affects and directly attaches to the ACE receptor. Once in the cell, what happens is this virus releases ssRNA, single-stranded RNA. Then there are 3 processes that actually occur within the cell. And one of the interesting things about the virus is it uses the host's biology and cellular makeup to create more virus. This all happens in the type 2 pneumocyte. So the first thing that happens is it releases its RNA. Then it goes through a process of transcription, which is an enzymatic reaction, and it creates proteins. So it creates all different proteins of this virus in itself. The second thing that happens from an enzymatic process is more RNA is synthesized. It's combined with the host biology and creates and synthesizes more RNA. Then the third thing that happens is another enzymatic reaction that takes these proteins, which are all the makeup of the components of this virus, with the RNA, single-stranded RNA, and it puts it together and it creates more virus. So what happens is, as this is occurring within your type 2 pneumocyte, it creates a bunch more virus. The virus exits the type 2 pneumocyte and destroys it in the meantime. So the type 2 pneumocyte is destroyed, it can no longer create surfactant, and we've created a whole bunch more virus that now goes back out into the lungs and starts a different process. Okay, so really important. The key factors were the S protein spikes, being able to genetically unlock the ACE receptor, invite it into the cells, release ssRNA, create proteins, create more RNA, put it together, create more virus, out it goes, pneumocyte destroyed. All right, so then what happens is the pneumocyte's destroyed, and that's the pneumocyte right there. It sends a chemical mediator messenger to the macrophages because it's destroyed. Now there's an immune response, the initial immune response that's going on. So the macrophages, they do something called releasing cytokines. The cytokines, the major cytokines that are in play here released from the macrophages are your interleukin 1, interleukin 6, and your tumor necrosis factor alpha. Okay, so this is really important as well. These are major inflammatory cytokines that start to cause havoc within this alveolar as well. So it attacks the virus. As it attacks the virus, it starts to wage war within that alveolar itself, but it doesn't just wage war against the virus. There's casualties of war. So these type 1 pneumocytes start to take some damage. Okay, so we're starting to get some cellular damage in the type 1 pneumocytes. The other thing that happens is this interleukin 1, 6, and tumor necrosis factor goes into the alveolar capillary network. So as these cytokines go into the network, what happens to that? Well, it causes vasodilation. So it causes that capillary network to dilate out. It also causes it to become more permeable. So it becomes more permeable and fluid starts to leak out of the vasculature. That's important because the fluid will now start to come into the interstitial space, creating a larger area, a larger membrane that oxygen and CO2 have to diffuse across to participate in gas exchange. So you can start to see how now maybe this person might become a little bit hypoxemic because gas exchange is interfered with. The other thing that starts to happen though is we start to get this process where we have leukocytes that go into help with this process. So now we have more an immune response, a larger immune response going on within that alveolar, and it's killing cells. It's killing viral cells, right? It's also destroying other cells. So what's happening is we get fluid that's going in, we get cellular debris that's now accumulating within these cells, and this is healthy cellular debris or breakdown of healthy cells. It's also breakdown of viral cells. So you have viral components and you have components of your type 1 and type 2 pneumocytes that starts to get in here, and this starts to paint a picture of consolidation. As this goes on throughout many alveoli, you start to get this consolidation picture. The other thing that happens though is this fluid doesn't just stay in the interstitial space. This fluid starts to come into the alveoli itself. So as the fluid starts to move into the alveoli, it starts to wash out more surfactant. Not only do we have a reduced production because the type 2 pneumocytes have taken a hit or have been destroyed, but we have fluid that comes in and starts to wash out surfactant. When we wash out surfactant, the wall tension of that alveoli increases, and we end up having alveolar collapse. So when this alveoli starts to collapse, it's consolidated, and it creates more of an inflammatory response than what's going on. So you can kind of see the picture. We get consolidation from all the cellular debris. We get fluid moving in and out from your cytokines that have caused capillary vasodilation and increased permeability. And so when you think about what that might look like from a patient perspective, right? They have a decreased ability to oxygenate and remove CO2. So that will stimulate a peripheral chemoreceptor response to increase their respiratory efforts, so they'll become tachypnic, increase their cardiac output, so they'll become tachycardic. The work of breathing is increased because these alveoli are now collapsed, and you have to breathe harder to get more pressure and more flow to open up those airways to participate in gas exchange. So that will be noted as an increase in work of breathing. Clearly they become hypoxemic. They become hypoxemic because we have less area participating in gas exchange because of consolidation. As well, we have some shunt effect when we have large dilated out capillary membranes. Hypoxia may be down the road when your tissues now no longer get the amount of oxygen that's required. So in the brain, when this IL-1, IL-6, and your tumor necrosis factor alpha, when they get into your bloodstream, it can travel up to your brain. And in your brain, obviously there's the area called your hypothalamus. So your hypothalamus will respond to these specific cytokines. And what happens from that perspective is it will release certain prostaglandins to reset the thermal regulatory mechanism that it's normally responsible for, and tells it to increase the temperature. So that's why you'll see fever. So in review, you can kind of understand all of the bits why you'd become tachypnea, because of your hypoxemia, because of the consolidation and the fluid. You can understand why you'll be tachycardic, because we need to increase our cardiac output to oxygenate the tissues. You can understand why we have an increase of work of breathing, because we have to open up those airways that are collapsed. You can understand why we're hypoxemic, because there's a larger thickening in the membrane, less gas exchange potential. Hypoxia if we don't meet our tissue demand, and we just talked about fever. When this becomes more of a global issue, more and more of these alveoli are affected, we start to get what looks like an ARDS picture. And when we talk about an ARDS picture, it's something that affects entire regions of the lung. So you have bilateral patchy opacities throughout your entire lung field, and so now we've got a real oxygenation gas exchange problem. Later on though, unlike ARDS from sepsis, which usually is a metabolic issue with then leads to ARDS, this now is a primary ARDS picture. But all of these markers, all of these cytokines, if they get into your systemic circulation, can cause a systemic inflammatory response and lead to all of these things from a global perspective. So you can have dense distributive shock with permeability, with capillary leakage throughout your body. And now you can become a metabolic, more of a septic type of a picture as well. So in a review, that's really how the coronavirus gets into our alveoli, how it affects our type 2 pneumocytes, how it creates more virus, the havoc that it wreaks when it creates more virus, the signs and symptoms to be watching for, and what it can lead to down the road. Important key features of COVID-19 is the fact that it affects your different organs in two different ways. One from a direct insult or a direct hit to that organ, and one from a secondary hit or insult to the organ through a perfusion issue. So it's really important, I think, that we just talk about some of the things from a neurological perspective separately. The other organ systems like cardiovascular, we talked about respiratory, but GI-GU and some hepatorenal stuff is going to be discussed in a little bit of detail during the patient assessment coming up next. So what we think we know about the coronavirus in terms of a neurological perspective is some patients are presenting with an encephalopathy, and really what that's presenting at is some of the decreased level of consciousness or raised intracranial pressure. So we don't always know that it's this ILI COVID issue. They just present encephalopic and with an increase in their ICP. The other thing that can happen, and we know this, that there's an increased frequency of seizures. So patients might present with seizures and you're going for a seizure call, and it's actually related to COVID-19. CVAs are another thing. Thromboembolic events are increased during somebody who's infected with COVID-19 because of its relationship to the coagulation cascade. Also, there's an increased risk of hemorrhage, and this could be intracerebral in nature, as well as a direct result of how COVID plays with your coagulation process. So you can have raised intracranial pressure from a bunch of these different mechanisms, resulting in a decreased level of consciousness. So be aware from a neurological perspective, it may be a COVID-19 issue when you have somebody who presents with a decreased LOC from raised intracranial pressure from either encephalopathy, maybe they've had seizures, a CVA, or hemorrhaging within their brain.
All right, so we're going to start talking about testing now. You may see patients in the field where they tell you that they've received a swab test and it's negative. Does that actually mean that we can 100% count on the fact the patient doesn't have COVID-19? Well, let's talk about swabs. So the standard test, if somebody is considered to potentially have COVID-19, is to go in and see their physician and have a nasal and an oral swab done. The nasal swab is done back of the nasopharynx in an effort to obtain some of the virus, that single-stranded RNA, and test for COVID-19. The oral swabs are done for looking for other things like RSV, influenza A, influenza B. The process I'm about to describe to you is the same for both. However, the nasal swab is specific to the coronavirus. So what they do is they take that swab, they send it off to a lab for testing, and they extrapolate out that single-stranded RNA that Rob talked about earlier. If that RNA is present, well, they're not 100% sure if it is or isn't at this point. So they take the swab, they look for that RNA, and they go through a process of reverse transcription. What reverse transcription does is converts that single-stranded RNA back into DNA.
Through that process, they apply another procedure to multiply that DNA so that there's enough of it for testing purposes. Following that, they apply a color to that potential DNA and run it through the PCR testing. PCR testing stands for polymerase chain reaction testing. And that is done where they take the color, they apply the testing, and if the color is found to be present, then you are considered positive for COVID-19. So is that 100% accurate? That's the real question. Truthfully, that we know that the sensitivity of this testing is about 70%. So what that means is if you test negative, there is still a 30% chance the test was wrong, and you actually can't rule out the fact that you have COVID-19. So even though somebody has received this testing, gone through this process, and they've been ruled negative, there's still a 30% chance that they still have the virus. However, there's some cool things on the horizon right now, and let's talk about serology. So serology is something that's on the horizon here. It's a form of testing where they're looking for antibodies, and it has some pretty big implications for how we as healthcare members and society as a whole are going to move forward with this. So it's from a high-level perspective, really what they're doing is drawing blood, applying it to a testing strip, and looking for antibodies. Now, as Rob already explained, if you consider the lungs, the virus is broken down, or not broken down, but has been proliferated throughout the lungs. And the process of phagocytosis, where cells come and engulf that virus, takes place. Now, once that happens, there's a movement into the bloodstream of some of the virus, and the helper T cells, which you guys are probably familiar with, they start the process of releasing cytokines in an effort to try and deal with the virus that's in the bloodstream. Once those cytokines are released, aside from the effects of vasodilation and everything else that has occurred, a good thing that happens is the activation of B cells. And these B cells transform into plasma cells. Now, that's all fine, but the key component here is the plasma cells release antibodies or develop antibodies. And with that antibody development, this is where the really cool part comes in. And they develop early on in the disease process, or the fighting of the disease process, they release antibodies called IgM antibodies. So if the serology test is able to determine that IgM antibodies are present, it means that you have the virus and it's active. That active virus means that you may be symptomatic or not, but what it does do is can possibly confirm that you may be shedding that virus and thereby be contagious to other people. But this is where it gets really cool. About a week to 2 weeks later, the antibodies that are developed change into IgG antibodies. Now these IgG antibodies give us an indication that you had the disease. Now that's awesome because, and we don't know for sure whether people can be reinfected or not, but if these IgG antibodies are present, what it allows us to do is state you've had the virus, and if you can't get it again, you're essentially immune to it. So does that mean then that we can go back to healthcare work or be out in society without the risk of shedding the virus or without the risk of recontracting that virus? Now we don't have all of the details yet, but this is a pretty interesting thing that's moving forward and has some pretty significant impact worldwide. Now, the last question you're probably asking is, okay, Chris, well that's great, but what's the sensitivity of it? We talked previously about the swab test having a 30% false negative. Well, they know that the sensitivity in conjunction with the swab test, because you do both, you don't just do one, but in conjunction with the swab test, the sensitivity for this is 97%. So that's really high and really accurate. So a 3% false negative rate. So this has some pretty profound effects for the future and has very promising. We'll see what it looks like. It's not something that's readily available at all hospitals in all communities currently, but moving forward, we'll have to see how this presents. All right, so let's move on now to patient assessment. This is stuff that you can apply in the field that will hopefully give you some value in assessing whether or not these patients are COVID-19 patients or you find concerns. So first and foremost, BCEHS, the doorstep assessment is imperative that you do prior to entering the residence. We know that you'll be wearing proper PPE when you get to the call. And so you want to ask the patient if they have a cough, a temp, if they have a sore throat, or if they're having any difficulty breathing. That obviously is for your protection in deciding what level of PPE you're going to wear into the call. Once you get patient side, we want to consider what's happening within the body, and we want to consider the vital signs. So let's speak about blood pressure. Patients with COVID-19 can either present with a high blood pressure or a low blood pressure. For sake of ease, I'm just going to put some numbers up here. These are not exact numbers, but just so we're all talking the same language here, we're going to consider hypertension as a systolic blood pressure greater than 140 or a diastolic greater than 90. If we're talking hypotension, a systolic blood pressure of less than 100. With regards to blood pressure, if you find that they are hypertensive, it's an indicator of worse outcomes. A lot of the research or the expert opinion they're starting to find is that patients that present primarily with a hypertensive vital sign that end up doing worse. So if you find somebody that you think is COVID-19 and they have a higher than normal blood pressure, in the back of your mind you need to be thinking this patient could potentially do worse, and that may change some of your transport decisions. Now, low blood pressure, if they're hypotensive at less than 100, that is usually indicative of somebody who has an infectious process, more of a distributive type shock. So if you find somebody who's hypotensive, you want to be considering whether or not they have sepsis in the background, because patients can have COVID and other superimposed infection that can complicate matters considerably. They basically end up with this super infection. So finding somebody who's hypotensive with a suspicion of COVID is something to be very concerned about. Now, heart rate. So again, these patients tend to be tachycardic. Again, using an arbitrary number of 100 to represent tachycardia. If you find them tachycardic, it's usually from one of two general causes. The first one being that distributive shock, low blood pressure. The heart tries to compensate by increasing rate. So that's a potential. But the other one is these patients, as Rob explained previously, have a great degree of hypoxia, or can have a significant degree of hypoxia. Again, with poor delivery of oxygen to your end organs, the body's compensatory mechanism is to increase its cardiac output. And one of the key indicators of that, of course, is increasing in heart rate. And finally, Rob talked already about temperature, but finding them with a temperature of greater than 38 degrees should be an indicator that you would be thinking, I wonder if this person is a COVID patient. So that's your vital signs. Now let's move on to your physical exam. Obviously you're going to do a full physical exam, as you know that well. I just want to highlight auscultation of the lungs. Again, it's very important when you are auscultating the lungs to make sure that you have proper PPE and the patient is not coughing or breathing all over you. So please be cognizant of that when you're going about this. The interesting thing about COVID-19 and the effects it has on the lungs is that you can end up with pretty much any of the normal standard breath sounds that you hear on several different types of patients. So you can have that bronchial breath sound. That's generally a referred sound. It may give you an indication that these patients have some sort of ARDS picture or consolidation in their lungs. So if you're hearing that and you have decreased air entry at the bases, it should give you an indication that, oh, I wonder if there's some kind of consolidation going on. You can also get wheezing. It's not uncommon for these patients through the inflammatory process to have their airways constricted, thereby presenting like an asthma type patient where they have that narrowed airway with air trying to get by, producing that high-pitched wheezing sound. That could give you an indication that they need to be treated with a beta-2 agonist. As well, we talked about the proliferation of the disease and the accumulation of fluid within the lungs, that gunk that can appear in the alveoli. That can cause crackles as the alveoli pop open. As well, because of the general assault that this has, it can do either perfusion-based or organ-specific. If the heart is affected, cardiac output can be greatly decreased, and when cardiac output, especially left ventricular cardiac output decreased, you can end up with a backwards flow of pressure similar to somebody who's suffering from congestive heart failure, and they end up developing pulmonary edema. So those crackles could indicate either atelectasis from pulmonary edema or atelectasis from the buildup of infectious process within the lungs. And finally, you can get that loud rhonchi sound, and that's upper airway generally, and that's because all that mucus that's being produced, as people try and clear it, it tends to sit in the upper airways and cause that loud rhonchi sound. So don't be confused or don't be fooled by thinking, oh, well, wheezing means they're an asthmatic. Don't forget, COVID-19 can attack in several different ways, and all of them can present with these sounds. So let's move on to patient assessment, labs, and diagnostics. So I know that not all levels of paramedics have access to all the different levels of laboratory medicine, but it's important to understand what's going on or underlying and what it presents with externally. So let's start off with the end organs. We've already kind of covered off neuro, but we're going to continue and address respiratory, cardiac, renal, and liver. So let's start off with cardiac. All these patients are going to require a 12-lead electrocardiogram. Just to review again, coronavirus has a perfusion-based injury to organs, or it can cause an injury directly. So when you do a 12-lead electrocardiogram, it's not uncommon to see patients with different types of dysrhythmias. You can get brady, tachys, PVCs, PACs. There's a whole myriad of things that will be reflected within the cardiac electrocardiogram. Of course, you're also looking for STEMIs, NSTEMIs, or acute coronary syndrome. And one of the other things that more generally done in the hospital is measuring out a QTc, because some of the treatments that they can give, although they're kind of coming out of vogue, cause a prolongation of your QTc. So it's something to be aware of. From a laboratory point of view, you're going to find increases in your troponin and increases in your CKMB following the following any cardiac damage that you might find. Okay, so moving on to respiratory. Oh yeah, actually just one other thing to quickly talk about there. There's a really interesting study that's just been released. They've done a look at the cardiac arrest data out of Italy. And when they analyzed that from 2019, so pre-COVID, to 2020, the post or concurrent COVID period, they found that there's been a 77.4% increase in out-of-hospital cardiac arrest. So that's a startling number, and it could be reflective of the injury that's a result of perfusion or direct organ injury, or we're going to talk about coagulation and the hypercoagulable state that these patients end up in. We're not sure what the result is, but a startling number indicating that COVID has a massive effect on cardiac. All right. So moving on to respiratory. We've already covered off a lot of respiratory, but I just wanted to speak briefly about what the patient's process is and what you're going to see in the field. So, as Rob's already explained quite well, the patients are going to have a decrease in their SpO2, so they're going to have less oxygen available. The body's compensatory mechanism, of course, we talked about increased heart rate for delivery, but there's also an increase in respiratory rate. As those chemoreceptors are stimulated, the patients start breathing faster, and they become tachypnic to the point of trying to compensate for low oxygen. When patients are breathing rapidly, one of the things that happens is they blow off a lot of their CO2. So some of you may be familiar with this equation. This is the carboxy anhydrase equation. And you'll see that basically water and CO2 become move through this equation to hydrogen and bicarb. So hydrogen is an acid. So it's really important to know that as patients breathe quickly, and you're going to see this in the field, they'll be tachypnic, but they won't be overly distressed, not LOC failing or really unable to breathe. You're going to see that they blow their CO2 down. As their CO2 goes down, their hydrogen or their acid goes down, which means their pH goes up. Thereby, they are in a respiratory alkalosis. So if you are able to get arterial blood gases, you'll find that they are in a respiratory alkalosis. As the disease progresses, as they start to become less able to maintain that tachypnea and that ability to try and compensate for hypoxia, they begin to not be able to breathe as well with minute volume. So what happens there is, instead of the CO2 going down and the hydrogen going down, it goes in the opposite direction. CO2 goes up, hydrogen goes up, which causes the pH to go down, and the patients, again, will be in a respiratory acidosis. This is where they are really struggling to breathe and they're starting to decompensate. If you are able to draw ABGs and you find them in a respiratory acidosis, it's a very concerning finding that this patient is going to no longer be able to compensate for their hypoxic state. And finally, if it progresses through to an infectious process, one of the things that will happen is that the bicarb within the body will be used to buffer, and the bicarb will start to drop. As the bicarb starts to drop, there is a differential between the acid and the bicarb. So there's essentially more acid than bicarb available. When you have that higher level of acid, these patients end up in what's called a metabolic acidosis. So that's the body is causing the acid. And so again, if you're able to draw ABGs and you see a metabolic acidosis, there's concern that there are other findings, other disease processes, or COVID directly is being involved. All right, so continuing to move on here, let's move on to liver. So again, to just reiterate it, it's either perfusion or direct organ injury. So liver is really going to be testing through laboratory medicine. So you're going to find that in the case of liver, the liver enzymes are going to start to climb. So that means the liver is starting to take injury. And if things get to the point where the liver's got reduced function, the liver function tests are actually going to get worse. So that's the liver function tests, or thing like your bilirubin, your glucose. Lactate's an interesting one because the liver clears lactate, so either it's not clearing it very well, or the body's producing so much that the liver can't keep up. But the most interesting one is INR. So that is part of your clotting factors, a representation of your clotting factors. So your INR and your PTT can change considerably. Patients who have COVID-19 have also been found to have hypercoagulable states. So they start off with a real high degree of clot production. As well, their ability to break down those clots is reduced. So they end up in this hypercoagulable state where they are producing a number of clots, which can cause a whole myriad of factors. We talked about strokes in the past when we were talking about neurology. We've talked about potential STEMIs, pulmonary embolisms. There's a whole bunch of things that can happen with regards to clotting. So that's one side of it. The other problem is, as the disease progresses and as patients spend more time in this hypercoagulable state, they use up a lot of their clotting factors. So now that they've used up all these clotting factors, there's nothing causing the clots to form anymore. So they end up in DIC and they become profusely, or they will bleed profusely. So depending on where they are on that continuum, they go from hypercoagulable, causing all the clotting issues, to DIC, where they now become high or have a higher chance of blood loss. So very important findings. Again, moving on to the kidney, this one will primarily be through labs again. The big key indicators here are going to be your creatinine, your urea, and your GFR. Direct organ assault on the kidney can cause a whole myriad of changes with regards to your electrolytes. And if you have perfusion-based issues, it can cause problems with your GFR, your urea, and your creatinine clearance. So it's very important to know that if you see a rise in these things, consider that the kidney is taking a direct assault as well. So that in a nutshell is really the patient assessment from a organ-based perspective, and hopefully that had some value. Thanks very much for watching. I hope you've enjoyed the presentation today.
If you have any questions, we'll have our email up and available for you. Please feel free to reach out and we'll be happy to discuss things further.